kind of background piece. Well, hello. Ooh. Hi. I would like to call this meeting to order. I'm Dr. Neatfeld. I'm the current president. I would like to welcome you all this evening. We have Dr. Ha, who many of you already know. She works with us at Christus Health, mainly with our inpatient service, but is very generously willing to offer her advice in other situations. She is a teaching faculty at UIW. She's often seen with her pharmacy students around our hospital. And she very kindly agreed to give us some information about DOACs by the request of one of you all. So please join me in welcoming her. We do need to technically approve the minutes first. I don't know if you all have had the opportunity to look over them. They are on your tables. Is there a motion to approve? Second? Okay. Hearing no further discussion, minutes are approved. Let's see. The treasurer's report, bank balance as of 4/18 is 52,257.97. In terms of announcements, if any of you all know any medical students, we do have some scholarship opportunities open right now, so we would invite them to apply. We have sent that information out to the local medical schools, but just always never hurts to give it a little nudge. And then our next meeting will be ethics credit with Dr. Henderson talking to us about kind of some ethical issues, things that people don't necessarily think about. But now we have a quick message from our CME sponsor, Utesca. Yeah.
All right, I'll just. Oh, I see the mic is dead. Hold on one second. All right, I can project for a little bit. All right, thank you guys for joining us today for the South Texas Regional Family Medicine Grand Rounds. Our educational partners today are of course, the Texas Academy of Family Physicians Alamo chapter. And our department's mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. Thank you in advance for being attentive to the presenters and engaged in the session, for registering for CME credit for each session, and for completing and submitting a session evaluation form. If you are attending virtually, thank you for muting your microphone and keeping your cameras on when appropriate. Today is April 22nd, 2025. You can register attendance and claim credit using the CME credit via text system. Send a text to the number on the screen, 844-502-1338, with the email connected to your profile, and then text attend1009-6275. Again, today's session code is 1009-6275. AAFP members can use your AAFP login and claim credit for this activity online at the link on the screen. This live activity, the South Texas Regional Family Medicine Grand Rounds, has been reviewed and is acceptable for up to 1 prescribed credit by the AAFP, and physicians should claim only the credit commensurate with the extent of their participation in the activity. Our Grand Rounds address the following nationally established physician core competencies: the Institute of Medicine core competencies, the ABMS ACGME competencies, and the AAMC competencies. All right. And I'll hand it off to our speaker. Let me go get that mic. Okay, I'll just start without it.
Thank you. So I want to welcome everyone here this evening. I want to take the opportunity to thank you for inviting us to speak. And so my goal for this evening is to provide you just a good primer view on the clinical therapeutics of your DOACs, your direct oral anticoagulants, to help supplement your practice and to help supplement your practice and also to manage the patient on board. So we're looking at our plan. First, we're going to start off by doing basic pharmacy. And that right, we have a good foundation and to understand a lot of the aspects that we talk about. Well, then we're going to talk about indications. Talk about indications in which you can avoid pregnancy. And talk about those images. Best, starting around the mom. In addition to this, let's talk about some important factors to consider in selecting and initiating the ratification. And then lastly, we'll conclude by talking about practical nutrition around area engaging preoperative stop, and then also DOAC. All right, so I will start off with two. And so the question is, warfarin has been FDA for which of the following indications? Select all of the following. Is it A, myocardial, B, deep vein thrombosis, C, anti-muscle deficiency, and or D, cerebral venous sinus. Right? Okay, so we're selecting one answer here. Yeah. So, deep vein thrombosis is the obvious. And although women did not agree with anti-muscle deficiency or venous sinus thrombosis, it is related. Now, other indications which warfarin is also indicated for is anticoagulation with PE, right? Anticoagulation for prosthetic heart valves. And then also short prophylaxis of atrial fibrillation. And then lastly, you guys understand this. It's also you so fun fact. Guys are white in the United States. He got warfarin. And he survived. And all the headlines said our president received rapid. So, but then, he survived. The same one with the medical department. But now, obviously, therapy has been replaced by therapy. So, we no longer. So, let's take a look at the, development of your oral anticoagulants. Early 1950s, one of the first oral antibiotics available for use. Okay, we've used it for many years, very effective. It's the agent with most indications, both at FDA, as well as off-label. It's the one we have to use. But obviously, it's so we have the PhD research. I didn't come up with the agents. We finally did in 2010. The biggest thing, the first DOAC. Closely following that are the 10 inhibitors, with rivaroxaban, which is a relative extent, which is unprecedented with dots. And these newer, the direct order, the DOACs, they mitigate advantages for the donor. They allow us to enter the era of new anticoagulants. So what are the advantages of DOACs over? Is it A, less monitoring? B, more immediate onset often? C, you drug interaction? D, only if B, everybody agree? Everybody concur? Excellent. No. It is the often. So probably the greatest advantage of the DOACs is much less with more getting that therapeutic it's tightly with the DOACs. Let's see, it's tight, it's just that it's dose. The DOACs also have more immediate onset and more repetitive, 5 days to begin. We have Bridget, it sticks around a long time. 30, 40 hours. So if you're trying to wait for surgery, you gotta wait well, you gotta reverse it. Okay. And it's very quick. With the DOACs, wait once it, you will. And you have no time short. So waiting for surgery stops days before. It's very predictable. Also, DOACs are way easier to use, right? We don't keep low, the titrating to the therapies on. In most patients, rather than probably 50% of the times, these doses, no. You know what? Then we have fewer drug infusions. They do have a few in our. And with food, the only thing you're not really worried about is probably with the lockdown, where you take the food to the side. But that's only in 15. They were in this net, newer, novel, that's what we first and they were new. 10, 15 years of experience now, they're no longer novel and new. So there was a lot of things that around. Some experts like we should probably call them non-5-chain antagonists. That was the term no. Some people like, no, kind of like how about sodas? Target specific. People like not possibly, but it's still hard to say it. Just right. And then lastly, the terminology of DOAC. So that's your direct warning. So this is the preferred. That's funny because my students they're thinking tomorrow. So they come back. Oh, what? I don't typical Gen Z. But anyway, we will still be maternal. It's not wrong. It's just that the preferred term now is definitely direct one. I need to be called beforehand. Well, it really boils down to the basic pharmacology. If you guys can call warfarin works by inhibiting the vitamin A, that's needed for the synthesis of vitamin A. 279. So it's got a very, it hits pretty far along the entire coagulation test. Now your DOACs, they hit a little bit more downstream and they're more specific. Your 10A inhibitors, they reversibly bind many versions program too. And then the thrombin inhibitor binds reversibly to thrombin, depending on the conversion fibrinogen. So very nice anticoagulant, right? The mechanism is much more specific, much more direct. We call it. look at a case before we. So we have a 64-year-old gentleman. David, which is cardioverted and he's now on a maintain more. And he currently has no hypertension, his cardiovascular, and it always which he has no medication, and there's the medicine. And if you weigh that up, it is all pretty appropriate for the issue. As far as survival, slightly hypertensive, slightly tachycardia rate controls, respiratory rate, temperature response, physical exams with unremarkable and laughing. So, but the big thing here is what you guys learned that something is not. So the question should be, why is he? We've talked about the significant advantages of the DOACs over warfarin. It'd be a lot easier for him, it'd be easier for you to manage. Also, when we talk about the FIB, even these. On selecting patients for DOACs and starting DOACs, you always have to make sure you have the appropriate indication. The two primary indications for DOACs are stroke collapse, so and then anticoagulation for VTE, whether it's DVT or PE. All the currently available DOACs have good safety and efficacy data, and hence are approved for these indications. Now, we're studying the indication that needs to avoid patients with mechanical heart valves, anti-phospholipid syndrome, especially things, positivity or stroke, devices, and patients with changes that they were valve replacement or implantation. We're talking about who have no current indication to make. All of these patients, they DOACs are not on. Mainly because DOACs, when they look at the studies, they have poor efficacy compared to warfarin. And we don't use it most. Now, more specifically, 5% of heart valves with no current indication. These indicate, well, this particular indication in these patients, there's not as much data. So we can always use the warfarin. There is no data. That's why it's generally not recommended. But this is an area where we're seeing a growing body of evidence where you actually may be able to consider it, especially gospel. It can show the safe and effective, so the recommendation may change. Now I want to focus more on valve fibrillation. Now, valve fibrillation currently, and arguably defined AFib with mitral stenosis, whether it's due to rheumatic mitral stenosis or mitral disease, or a lot of or AFib in patients with. Now, for these patients, the definition of AFib is well, for this discussion, we're going to go with the standard definition is right here. The DOACs are not recommended because we have to. These patients, they were never included in any of the data. For your mitral stenosis patients, the reason why they were excluded was because they have a higher underlying risk. And then the patients with AFib and heart valve, they were excluded from the trial mainly because of the higher with AFib and mechanical heart valve, it makes sense. Not work if you're doing, but AFib with mitral stenosis, this is where we don't have data, but we don't have data. So once again, an area where there's might be a basic patient on the DOAC, but leave it up to the client. Other some patient populations for which you should avoid DOAC too. All of the DOACs delivered to very degree. They are recommended for but if there's a lot of weird potency, then I don't have any studies, but animal studies do show increased risk of bleeding. The fetus, also, obviously, other So definitely recommended working there. Lactation, you can do being studied, but animal studies can show excretion of breast milk to avoid the So here, remember the mics are very expensive. We'll talk about cost savings. So if you got an uninsured patient, not a patient, you put on a DOAC, there's some patients. All those patients in the program, they have to disability, paper, there's, you know, a delay in therapy. So, you know, it's up to you. It's kind of challenging, but you're up to the challenge to work. Persistent AFibs and done appropriate indication for a DOAC. You also have these, the liver is okay. And guess what? He's insured. I mean, he's uninsured. And so, he's a great candidate for it. So, how do we start? Well, there's definitely a number of considerations that we need to think about. Efficacy and videos, they kind of go hand. Here we have efficacy data from all of your DOACs, pivotal AFib and BCPS trials. And I want you to know that, remember that all of these DOACs compared to work. So you're going to see that pretty much all of your DOACs are considered non-inferior for these patients, meaning, you know, no resident, nutrient, that's not maybe two exceptions. Tran and Pixie family were actually found to be superior related to warfarin, but in these patient populations in these studies that had no Tran VAS, so maybe have been more low risk that could have swayed the study a little. But it's still possibly superior. So with that, see, maybe not big consideration. Now when we look at bleeding, this is where you're going to see bleeding profiles. So here we're going to look at AFib studies, and the primary safety outcome in all of these studies was major bleeding. And major bleeding is defined as bleeding associated with hemoglobin fibrosis, bleeding with transfusion of personal BCPS, that critical bleeding at site, critical site, and then lastly, fatal bleeding. So that was the major bleeding. Major bleeding, what you're going to find is that the biggest bleeding and the paroxysm had no difference between them. Whereas the Pixie and doxing lower risk. Intracranial bleeding, which is the one who really but the caveat for GI bleeds, all of the DOACs had greater risk of GI bleeding, except for a Pixie, which had no difference. So the bleeding is just as similar. Now, when you look at the BTE trial, once again, there's like differences. And the PB trial, fixed advantage, so low major bleeding. What we can do here? Well, I think we really need to look at the data from a full account. Don't allow to get better conclusions. And so there's actually a meta-analysis that was done by American colleagues, and they looked at all the AFib. We'll look at AFib because it's going to give us more insight on intracranial AFib. And what they concluded is that your DOACs compared to over have much greater AFib. Major bleeding, intracranial bleeding is much less severe. But unfortunately, once you can always agree, there's a greater risk for GI. But with net benefit, that's preferred for both AFib and BCPS. But you're like, okay, Dr. Hien, you didn't answer our question. Is there a DOAC? All of the studies have compared the DOAC to warfarin. The trials of DOAC. And that's what we really think. All the DOAC compared to warfarin. Maybe one looks very check. Which one was that? Right? Definitely obviously and typically it's just going to end right here. So it looks distracting. And then you can think about so once you grow up down. Very consistent results, but once again, very slow. But if you're trying to find that inside the lives, right, where I want to mitigate minimal years as possible, you can weigh that to the decision making and go with a fixed demand. You definitely strong level of head trials. About leading. Let's talk about the first effects of all of them. So we're going to talk about basically which is the primary safety. Basically, we're DOACs. Leading risks for basically anywhere from 2.1 to about maybe 3.6%. So not that. Intracranial bleeding is much less than 0.5%. See, GI bleeding is obviously right around 1.2. And so that's like very important to monitor the patient while continuing. Different for specific training up to about 35%. Doesn't appear to be training, but if it's persistent, we can try to use to impact, yeah, which is good because now we have more. The form did it, just kind of. We talk about efficacy bleeding risk. Now let's talk about in this important patient, and then we go particular renal affect the selection of your DOAC and then your dose. All right, so which is the following DOAC can be used in patients with renal like A, penetrant, B, neuropathy, C, apixaban, and D. Okay. There you go. And just remember, the patients with renal impairment, they're very heterogeneous these population rates, right? They have different stages of chronic kidney based on TFR, and then the worldwide, we can have practice as far as the calculated. You got the staging patient and then staging now. Or we're going to find that those things does vary with the different patients, but you can use them in all. Okay, so quickly, I want to look at the kinetic immunization. So you can see on the 1, 3, 4 hours, 2 hours, 3, 1, no. Now when we look at the elimination, you'll see that we all have significant inequalities. The biggest man has to look at 80%, document 50, and then we're rocking and fix again, slightly lower renal elimination at 33 and 25%. But with this renal elimination, probably have those cases to be functional. It's going to be a lot of. Let's talk about dosing. And here, dosing recommendations, we're going to first talk about AFib, which is the top level. So you can for AFib dosing, it's either twice daily, once daily. Once daily. So it's very convenient for you. It's really hard to take meds if it's once daily and like this. Now, when we look at BCPS dosing, it's a little different. Okay. So we're going to rock the day, you're going to see 2 trends. Rock the day and pick the day, you're going to load them up for the first 3 to 3 weeks, then you drop it on the maintenance. And the reason why we do that is because BCPS, we've got to pick up. And the greatest risk for recurrence of P or expansion to the first BCPS 2 weeks, 800. The other strategy is, is with the document utility. So after 5 to 10 days, I don't have anticoagulation, then you can start. Why well, it's not really rich. like point up in person, all by the okay, the reason why it's like this is that's the study. Okay, we got the fan, we did it many patients, the first little off potential calculation, then they were in about to the doctor the big fan. Study that way, big struggle there is when the big tank came out, where we had to put these patients on. So I think that's a big reason why the big training got to disadvantage on the business. Also about renal dose. And what I'm going to point out to you guys is we're going to see that renal dose adjustments differ based on the indication. So for atrial fibrillation, you can pretty much use all of your DOACs up to about the rapid clearance of less than 15. Okay. And that's because we have good data based on so if rapid clearance is lower than just going to dose it. Drop the dose again. Now, if you look at VTE dosing, notice that adoxybate is the only one that doesn't have any dose effect. Okay, why is that? Because once again, that's how the studies work. Right? So the VTE trials, they didn't have a subset of patients where they studied these different characteristics, and even with the experiment we'll talk about in a minute, there's no doses of dose because they didn't have that in the studies. So you can use them at the same standard dose of perspectives of 15, 30, you only have to do this dose of the type of studies. Now, because it's a little different. And that's how we let the studies and that's how it's done. Now, for patients with any stage renal disease and patients on renal, only agent that's to fix it. So that's going to be your drug work. And if they have end-stage renal disease, we're still going to do 5 PAD unless they have additional risk factors. So age greater than 80, or and then once you get your and then I'll be bringing you guys the data for hemodynamics. The PCA takes very weak. Okay, but they do have this recommendation, and we're not going to go too much stuff about it. So for the HPA, let's go by that, which is the reference. That they work suited. And then lastly, the doxybate is interesting. That's a black box point that's background clinics, it's greater than 95, it's supposed to be avoided. Is anything the one? No, I don't think I've been that. Well, actually, before. So what they found that all the patients with pregnant greater than 95 have worse outcomes, greater stroke. Yeah. So renal elimination, that's what they're doing. And so they're cutting it to that. So black box warning what this is lost. All right, let's quickly talk about some additional implications for now. All of your DOACs, except for adoxybate, can also be used for further reduction of the recurrent DVTs and PVTs for that initial phase of 3 months, 6 months, whatever. So these are nice oral options for long-term treatment with PTD, usually like patients, right? Or patients with certain sadness, so to do more of those. All of your DOACs except for doxybate can also be used in obesity prophylaxis following orthopedic surgery, either hip or knee. So once again, nice options for discharge that will we're going to do more than that today. These are nice options that we don't have to do with the injection. And lastly, Xarelto or Rocket has just an additional indication. The first one is for VTE prophylaxis. Days. And I used to potentially know option that I can go with for VTE prophylaxis in patient, but still have My go-to is honestly more expensive, and it's not supposed to be charged. I don't usually recommend that in. I don't think the guidelines are really good, because when you look at the data, there's over 10%, so more reading rents at the stations would be better than. And then lastly, River Rock is also being used at a low base 2.5 PAD in combination with aspirin. What's aspirin? It's the part of that dedication to the chronic CAD. Yes. Because there's like data. So you can do that's what we used to years ago too. So it's important, and when we look back at the video, there's some studies that say it might not as a DOAC on the moment, but still, you know. Okay, finally, let's talk about cost. Okay, so I hope you guys have a very cost productive. Okay, here I have retail price plans for all of the agents. Based on the direction, you can see average tax rate paid on $600. So if patients not insured, there is a delay, and that's per month. Now the biggest trend does have a generic, but it's still, looks $300. So there, going to go to the court cases. The good thing here is that Texas Medicaid does cover Pennsylvania, and the biggest one. And then as far as Medicare Part D, private insurance, really depends on whether or not it's covered, and if it's drawn. Now we are going to explain where insurance are covering more. There's no cost there for the patient. So we also want to apply our recommendation or step up if we really have to try something further. Data that I read across, but it just basically confirmed what I thought. So if you guys see at the bottom, orange, clear dot line, and kind of light blue dotted line, that's what it's branded. People are tuned in its branded products. As you can see, much slower use than the DOACs. Still kind of consistent because we still have indications for which patients we work for. And then when you look at your DOACs, starting in 2011, the first one was released. It's kind of what I predicted. As the bigger chain and was on the market, Eliquis, which is a Pixaban, and the Rivaroxaban was also kind of took over. And then when you look at DOACs, and then this data is up to 2019, so that's been pretty forward. So we're pretty sure of the Pixaban and now let's talk about tolerance. So liver tolerance, we have these things. The most common one that you're going to do is probably when you give it with another agent that you have access to. So anticoagulants and big things agents are not conjugated together. To definitely use this together. Avoid use it if you can, but if not, so like for example, restoration of the hospital. Your anticoagulants are not that easy to get off the one that's was 7 years, but it's primary prevention. See if they're not, see if they're old. The next group of interaction we're going to talk about are a little bit more complicated. They involve the cytokine system and the P-glycoprotein transpace. So you guys remember cytokine system? That's that medical is that we have in the liver and a number of blood cells. And then the protein transport system, that's the main, but that is the and it's located in the gut, the kidney, the liver, brain. What it does is it puts the drug in. It basically helps to eliminate the drug. And actually, all of your DOACs substrate of cytokine grade 4 and the glycoprotein transpace. So they can be affected by both inducers and inhibitors. we're first going to talk about these. Now, when you give it with an inducer, what could potentially happen is and increasing risk. In here, what avoid your doing with any of these. These are the anti-epileptics, things on the world. They're not always very but it was funny because we were on service a few weeks ago, and there was a patient on criminal that we had came up with a schedule to take him off of it, by taking him. So it was pretty cute. And as far as your inhibitors, what could potentially happen is what? Decrease increase level, increases. Strong and moderate. And the recommendation is going to vary on the age range, dose of the DOAC, the real okay. But for example, it's strong inhibitors like duodenum, fetoconazole, or something with a pixidane. If they're taking 5 or 10 days, you can reduce the dose by 50%. But if they're not around 2.5, already in high risk of bleeding, just avoiding this. And then with moderate inhibitors, instead of not applicable, right here, and there's a bunch of any questions about that? Yeah. So anticoagulant is not Genetron is. Yeah. So Genetron is it's a B. You're not because but with these strong and one, this is so strong. So it's okay with this. All right, so remember, no routine rounds are designed for this process. Fixed doses, you just have to fix it. You can't say it was increasing for components. So you want to do it here. Also, watch out for your interaction. It potentially affect it. Safety, you want to make sure this is meeting your editor, particularly your editor. And then, it's an exam, make sure you're monitoring time the symptoms. CDC, checking their DOACs. And then always get basic. So that you make sure that it's started and those just started if they're not doing it. We assess leading risk and monitoring risk. There's a number of that you can do. And I'm sure many of you are familiar with this. But has those one of those it's a point system based on and assign the point over and up, and then it gives you the percent rating. And then you can divide that into low, odd, high risk of bleeding. It's a decent tool to use, but I did want to let you know that it was actually developed in the 3-year development. It was actually developed only in a population statement on warfarin warrants. Fortunately, we have a new resource, it's called a DOAC. And this was actually developed in patients and been validated with DOACs. Very similar to the hazard score, it's just a little bit more specific. So when you look at it, age, has various categories in which is there. Also with the medications, depending on the risk of low life differences too. So another tool that you can use to assess the bleeding and more severe in patients, it divides it up to risk categories. Have any of you guys heard of the DOAC score? Oh, some of them done it yesterday. Now keep in mind too, DOACs can also interfere with the number of hemostasis. All your DOACs, PCT, PTINR, today there's increasing intake. But some patients might not have it. Others might tolerate it, so they have sensitive. Too, depending on what the lab is. And yes, it's very, very important. Look at data. Look at data on, what's this magnitude of elevation, how does it correlate to efficacy, how does it correlate to safety, and also what threshold correlates to efficacy. And so really very minimal utility in terms of checking these assays to get DOACs. So going back to our agenda, these guys work with candidate for DOAC. No one is from 2. What piece of information all you need to know is the IMR. It's IMR is important. So recommendation when you're switching from warfarin to DOAC depends on what the manufacturer is. And it varies, but you can see in the second column there, basically, you're going to start the DOAC when the IMR is less than 2, 3.5, or less than 3. And it's, you can always look this up, but the goal here is not remember this DOAC, we can do it quick. And you pick that number. Was it the 2.5? And that's what I just. Now, if you're going to a low molecular inclusion, you're basically just waiting for that. You just want to start to go back. Next, low molecular inclusion, or you can wait within 2 hours prior to that low molecular inclusion. The different recommendations. I would schedule it the next time with the low inclusion. A fraction, you have to remember, is much shorter. So you can actually stop the idea of fractionating and start it right away. Or by adoption, wait that completely down and start it. And then when you're switching from DOAC to DOAC, relatively straightforward. Stop and then start the new DOAC, right? At the next scheduled dose of the. Now, when you switch from DOAC to warfarin, this boxing and expand because that's what I practically use all the time. So what you're going to do for those 2 agents is start with when you start working with and at the next scheduled dose of the DOAC, we continue with the iron. Now, it's a big advantage of the document, no idea. Because once again, I don't use these, but you can use them, so that's just great. It's really cool. For the difference, it depends on your PP function. You can just overlap for that many days. And then for document, it depends on the dose that you run. So you reduce the dose by half, start working, and then you just stop the document. That's great. All right. Now let's talk about very positive medicine. So we're going to manage the DOACs is very important because we obviously want to increase bleeding risk. And it really depends on 3 major things. Bleeding risk to the review, and then lastly, the bigger trend, the renal. So let's first talk about bleeding. Here I have a bleeding risk patient for all the different procedures and surgery. And it basically categorizes them as minimal bleeding, low to moderate bleeding, and high bleeding. This is sideways. So use the scheme as well. It's very well endorsed. And so you can see different types of procedures have different bleedings. Now, for your minimal risk, kind of the risk is so low for bleeding. But for low, moderate, or high bleeding risk, and it really depends on the agent. But the big thing is from all of your data, okay, what you wanting to do is waiting for that to last and eventually die out. And so about maybe 3.5 lives, you've got some left, 5 left. So for low moderate procedures, all you have to do for all your DOACs, stop at 1 day. If it's a high risk procedure, 2 days, up to 3 days. There's an anesthesiology guideline that says 3 to 5. So they're a little different. And they base it on, so there was a study that where they did this, they found the difference, right? So they're like, it's okay to do this, but the anesthesiology guideline, they base it on that. So maybe that's what they're doing. If a man, in addition to less than 50, throw from being around. So you're gonna be a little more conservative. Low moderate risk procedures, 2 days, high risk procedures. Now, when do you use respiratory? Well, it depends on who is the procedure. Low moderate risk, okay. High risk, easy, pretty straight. Right. So, but if you do encounter, we folks know how to manage it in general. So when you're dealing with DOACs, you determine 2 days. The first one is, what's the bleeding severity? Is it a major bleed or is it a non-bleed? So if it's a major bleed, it's bleeding associated with or we have like everything else is a non-bleed. The reason why you need to know the difference, or you need to determine what type of bleed it is because your local agents are generally only recommended for bleeds because they do have risks associated with non-major bleeds. Even still, you may require some type of bleed. The other thing you need to determine is the degree of anticoagulation. So what you're trying to do here is, okay, so I can figure out how much drug is still in the body, how much anticoagulant that could be contributed to the bleeding. So here, it's been more than 24, maybe 30 hours, and the patient has good renal function, the half-life on average is 11 hours. By about 30 hours, less of the drug might not be contributing to. If you have a specialized look at a degree of anticoagulation, there's a test called the program, the degree train. You can check the anti-DNA levels, or you can use the log we're doing here that we talk about tomorrow. But there are specialized tests like specific anti-DNA or specific DOAC, like Pixaban and Rockland and the dump stand. And you can also check throughout consultation level. I don't really know what but a lot of hospitals specialize in. But the most important thing you need to know, if it's a major bleed, do not wait for that to come back before you do it. Got to do it. Okay, so what are our measures for treating DOAC-associated bleeding? Well, we should it's very straightforward bleeding is thought. And also bleeding that you can treat. Maybe you can track compression, some kind of surgery directed at the patient to control. Fluid resuscitation is usually important. It's also very important. And consider because it's so significantly renal managed. But I would really do if once again the dose is really big, or if you don't have a dose of age. Okay, that's the only time I would consider that. Okay. They're only generally recommended for major bleeding and uncontrolled. So for the bigger scan, first line is Pixaban, second line is Pixaban. A Pixaban and rivaroxaban you have in depth first line, Pixaban for the second line taken depth. Rivaroxaban, unfortunately, there's no FDA information. You can try and get something. Now, really quickly on the reverse case. So perhaps mine is on and and that's a cool, and it's a common factor today. Kind of like a fake today. That may contain non-activated coagulation factor 2, 7, 9, and 10. It's also not included in the statement. I just want to point out that DEX and 10A inhibitors, you have to figure out what type of dose they were on. So the last dose is taken. Dose is given low dose and high dose, but you don't know. And then with these agents, they're relatively quickly turn them off, pretty quick efficacy. So once again, you're still risk for quality. BT, stroke, and when you do a reverse agent and control the bleeding, it's always important to make sure you have a plan. What you're going to do with the anticoagulation to decrease the risk for routine. Okay, so that concludes our discussion. So all of your DOACs, substantial edge, warfarin, BCPS, and hopefully we can find we might take it. We're managing DOACs, right? We're patients. And I think this is how we're planning to be out here. Right, and I'll just open the door for any questions that you may. You can affect your years. I think that's why I've never had to deal with it. Anybody else know? That's what's my house is like. Yeah. So I don't know, like the official city, right? But that's one of the things. It doesn't have a long time. Is that long? My guess is it is kind of nipple filling, so maybe. Oh, yeah.
There's states of relative environment.
Okay.
Well, and it's like, hey, that's not there. It's like the deep prophylactic law.
So I got this. There were no excited about okay, yeah, so we don't always overlap for like travel and like long-term mobility and things like that. Yeah. It's better not to do it. And that's why I say what like the different components that about that there. And then I have to do the shut down. So they get one really interesting.
Like, what did she take?
Yeah, interesting. I give you like a rule of 10. For anything. Yeah. Yeah, I mean, maybe video. Great question. Yeah. What's the Xeralto's fun and acronyms, if you look, they're all around 7 to 16 hours. And Xeralto's probably right in yeah, it is. So Xeralto is 7 to 11. Fine. Yeah. So what they do is whenever they do those things, all of the research is kind of this. So when they came up with it, they realized that once they dosed it, yeah, that's a big thing. What's the indication for it? Yeah. So it's interesting because there's a lot of data that looks at the dosing of your DOAC. Now you get patient, they don't have to agree, but they're on two. Every time we know this is a show, it was a population, but it showed that when we undergo the question, there's a high incidence of oral static and oral failure. Oh, leading this issue. Maybe good. This is really. But yeah, I mean, probably not. Yes. And what's in the so I can't have all the conversation based on the. You should be working. And how much space it costs. Right, with the Contact with her. Maybe it's good. I do, that's interesting. And then on her back.